back to,
I'll say at that fact, the baby's in the nursery with Katie, so.
Well, that was just it, that's what happened with us, the baby was bad. She
Sure.
got called into the delivery and, basically got thrown into, what's this?
right.
Yeah.
Worst case scenario, I would have the physician hold the balloon in place and then the nurse can be instilling the fluid if you only have 2 people.
Okay, but ideally 3 would be better.
Ideally, in a perfect world, 3.
Okay,
That would just keep it going even faster. But when I show you then what's new as of June, then you'll see that it kind of negates the need for as many people. But this is how this would work now. So,
this is Dr. Barnacle, this is Erin.
hi.
We used to just hook up an IV bag and squeeze, and that's how we did it. We put 500 cc's and did a 500 cc IV bag.
Sure.
I think that just works better than the syringe. The syringe is too cumbersome, so
Yeah.
I'm not sure if that's what the new trick is.
So the new trick is very similar to that, but you actually get the IV tubing and a 3-way valve. So rather than just pushing in the full 500, you still have control with the syringe, because a lot of providers will want to say, I know that I put in 350 milliliters, whereas if you just squeeze the bag, you won't have that approximation.
Sure.
So that's why we still connect the syringe and the whole works, because that way then you can better approximate. I don't think it slows you down any, but we'll talk about that. So for you ladies, any question about just the inflation via the syringe? No, okay. So what is new? So if you grab the 500 cc bag like he's mentioning, the top shelf of the kit will come with IV tubing and a bottom little nesting spot for a 3-way valve. Okay, so how this works, you're going to take your 500 bag of fluid, you're going to spike it, you'll bleed the line. That's really important, because if you don't do that, when you go to pull your first syringe, it's just going to be pulling all the air through the line. So bleed the line, the other end is red on the tubing. It's red because the 3-way has a little red band around it to where you're supposed to connect it. So red goes with red. At that point, everything can only go together one way, and it's the proper way, because it's all male to female connection. So the syringe will go here. At that point, you'll connect it here to the catheter. As I mentioned, out of the kit, it's always open, so you don't have to even touch the stopcock. And then all that will happen is you'll be pulling back, and it won't make that noise when you have fluid, and then you'll push into the balloon. And that you'll just keep doing that until it's inflated. You no longer have to turn the stopcock, because there's a 1-way valve in here that prevents the backflow. So you can basically do that until you're sufficiently, happy with what's in there, or you're up to 500 because your bag will be drained. So that's how this works. It takes the turning the stopcock every time out of the equation, because the 1-way valve, the only time you turn it is at the very end. And then you disengage this part that you added to inflate it, and then you're good to go.
And then would you go ahead and then hook up your Foley bag for the drainage?
Correct. So,
Now, did we do that? Did you want to do that? You don't have to do that. She said
No, I
it's something that, okay.
And I just had it in a washcloth all night, so it would drain into the washcloth, not all over the patient. Because I didn't know what we were supposed to do.
yeah, so once you have this inflated, so we'll just pretend like now this is in the uterus. At that point, because it was up at the fundus, we're going to pull back on it because we want to seat this now against the internal loss. That's where the most effective tamponade is going to be. And then we want to lightly tape it to the patient just to keep it in that lower uterine segment. And then attach your Foley or urometer, which is nice from kind of a cleanliness perspective, but also it does allow you to quantify how much blood she's lost. So if you are really wondering, gosh, if she lost 500, whatever it is, you can always tell with the little markings on there. So that's kind of a nice way to handle that. So now once this is in place, and when you do tape it to the leg, one thing I always like to mention is you do want to be somewhat mindful of the stopcock, because worst case scenario, she'd roll in the bed and inadvertently open this, and then she's draining the balloon. So I always say, kind of get it up on top of the leg if you can, to prevent that from happening, even if she moved. Okay, so fifth step on the poster is flushing the lumen and monitoring hemostasis. So like we said, we've got the bag on here. It's draining from the 2 holes up at the top. Now, if you suspect that there's a clot that's obstructing this, now granted, before this ever goes in, ideally you will have removed any retained placental fragment. I always like to point that out to people, but if you suspect there's clots, You can take the bag off and you can flush through that lumen. The 60 fits nice. Just a word of caution on it, we don't want to over flush or get too flush happy, as I like to say, because obviously her uterus is already boggy. We don't want to contribute even more to that scenario artificially here with fluid. But it takes 25 milliliters to just get a dribble out the tip. So to actually dispel something, you would need about 30 milliliters of fluid. So that's what I always tell people, 30 milliliters of fluid, take the bag off, connect it here, and then all they need to do is just flush through. And then reconnect your bag and see if it resumes. The last step on the poster talks about removing the balloon. It can stay in for 24 hours. Does it have to stay in the whole time? No. You can certainly take it out before then. We already said about, it's a good idea to have the provider on hand if you're removing it, because obviously if they do resume bleeding and you need something more intensive, you need to have someone handy. 2 ways to take the fluid out. 1, you open the stopcock, it drains out, and you're done. The second method is probably more common. It's a gradual reduction in the volume of the balloon. So let's say, and this is just arbitrary, every 30 minutes you take out 100 milliliters. And so as you think about it, the uterus is gradually toning down, we're gradually withdrawing fluid. One benefit to that method is if she were to resume bleeding while you were withdrawing the fluid, you haven't compromised the sterility of the product. It's still in her uterus, so you could simply reinflate it at that point and continue forward. So any questions about that? Only other thing to mention on the poster, so all the connections I talked about, the red to red and all of that, when you get the next kit, it's here. Also on the poster it talks about proper placement. Obviously all needs to be in the uterus, all being the balloon needs to be completely in the uterus. If it dislodges, they need to withdraw the fluid, reposition it, and reinflate it. If that became a persistent problem, she's delivered a huge baby, she's very close to delivery, and this PPH springs up, and you just can't get it to stay in, you can support it with vaginal packing. Again, that should be very rare. It shouldn't be that every time you use the Valkyrie you need to use packing. We really want to minimize that as much as possible, just because it's another thing to remember to take out in the back side of this. But if they really try to work it to the funnest as much as possible in the beginning before positioning it, it should be a very infrequent situation. Any questions about that?
I like that, that's actually a nice system, so.
Yeah,
I think we're gonna like the newer, unfortunately, the one I ordered to replace the one we just used is the old one, but then we'll start getting the new
Like
ones.
I told you, I'll do it like I did in the
Yeah,
past.
yeah, as long as you're comfortable with it, What we needed to know is, what we didn't know is you needed 3 hands. Somebody's got to either hold the tube, or, push the fluid and open and shut the stopcock.
So you can do it the way you were trying to do it?
Mhm.
How is that?
You just need IV, like with the one that we have, we
So
just
what kind of
need IV
tubing?
tubing.
But will it attach to that stopcock, the blue stopcock?
This is just regular IV
So
tubing.
why,
Yeah, so if you put IV tubing, you spike the bag, because this is what your IV tubing is gonna
Yeah.
look like
Yeah.
without this thing on the end. You spike the bag and you squeeze it. If you have it connected up here, it's gonna go into the tube. So that's what I was trying to get you to do.
yeah, it wasn't happening.
What time was it?
Yeah, see, what he's describing is like this. So it would just hook in here, and then you squeeze the bag to get it to go into the device.
Yeah, because at first you were trying to do it here and you were like, it's not working, and I was like, I don't know what you're trying to get me to do.
Oh yeah, this one, that one is just gonna put fluid out the tip.
Yeah, that's,
No, no, but I wanted IV tubing,
Yeah.
that's what I was asking for, so. It's okay. It was midnight or 1 o'clock in the morning, so.
It always is when these happen.
It was like 6 o'clock in
It
the
felt
evening.
like
I baked it.
Was it?
Yeah.
Okay.
it was the end of a very long,
I don't remember. so.
everybody was tired, let's just put it that way.
So does that pretty much answer any difficulty that?
And you said any type of fluid, normal saline, LR,
How long have you been day shift for?
8 months.
It all just runs together.
Yeah, any sterile fluid is fine.
Yeah, because we've got 500 of, normal saline in the
I'm
fixes.
bloody gonna pull that with the.
Well, and you know what we need to do then is, I'll
Make
add
the
that
kits
to
list.
the
Yeah.
postpartum hemorrhage kit so that it'll pop and tell you to get that. So that's just one more thing to grab. Grab the Bakri, grab the
And the tubing.
tubing, and then grab the, but the tubing will be coming in it ultimately.
Yes, yep.
After June.
Right, and then
Got it,
grab the
yep.
500. So you'll just know boom, 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 boom.
I wish we would have had this in June.
Well,
I'm sorry, but that's okay. But at that point, you know, you're hemorrhaging, you're not.
I was
Punch
frustrated.
your doctor in the face. I was frustrated. I should have heard the news I was calling you.